So Star Edwards is a registered dietitian certified in integrative and functional medical nutrition therapy and is employed by Microbiome Labs as a clinical support liaison. Her expertise as a dietitian includes microbiome restoration, food allergies and sensitivities, and pediatrics. She is passionate about supporting her family's health through functional medicine and teaching others how to do the same. As a true introvert, she likes to hike, garden, write, cook, and watch for wildlife. She enjoys little adventures with her kids and looks forward to Boba Tea Tuesday with them every week. She's a personal development junkie, leading a self-care group, a goal accountability club, and has a few hidden talents, including clog dancing. Please join me in welcoming Star, and I'll let her take it away.
Thank you. Where'd you find this bio? I'm going to pull up my slides, but yes, I would say that this is a safe place to talk about our bowel habits. Like you were saying, you love to talk about your bowel habits. My family hates it when I talk about stuff from work, and I'm like, well, at least I can go to work and I have like-minded people there. So let me pull up my slides real quick. So today we're going to talk about those symptoms that your patients don't like to talk about, those bowel habits that you really have to dig into getting a lot of questions to get some answers for them, because first pass, they're probably not going to give you much information. So we're going to start off by talking about what are normal American bowel habits and what is considered healthy. Then we're going to talk about some recommendations for bloating, constipation, diarrhea when you don't know what the root cause is. And then we're going to jump into some specific conditions like celiac disease and community-acquired C. diff, SIFO, IBD, and our new total gut restoration study, and SIBO, and our new mega IgG 2000 binding study. So this was a survey that for 2,000 people. It was the American Gut Check survey. So they asked about their normal bowel habits. Over or almost half of participants went to the bathroom once a day. So the majority were going once a day. And the majority of them were going in the morning. And the majority of them had a stool that looked kind of like a sausage or snake. This would be considered normal. So if you're talking to your patients and wondering where they fall on the spectrum, well, this is what is happening to most Americans right now. Now, we're going to talk about if this is actually healthy or not. So most of them said that they had constipation at least once a month, or not the majority of them, but almost 30% had constipation once a month. And 35% said they had diarrhea once a month. The most common food intolerances, probably not surprising, are dairy, wheat and gluten, egg, corn, and soy. And the most common diagnoses were heartburn, IBS, GERD, diverticulosis, IBD, UC, Crohn's disease, and then last, celiac disease. 23%, so almost a quarter of those surveyed, said that they did have some type of food intolerance, which was kind of surprising to me. I mean, talking to patients, that's not surprising, but it's definitely not healthy that a quarter of our population has some type of food intolerance. 21% of them actually had a GI diagnosis, and 16% of them have a GI doctor. So that did seem pretty significant to me, that 16% of us have such intense GI symptoms or diagnoses that we have to be referred to a GI specialist. So the best region for bowel health, which part of the country has the best bowel health? And it comes down to the West Coast. The Midwest was almost the worst. The Northeast was pretty good, but the South was actually the worst when it came down to bowel habits. So a question for you, if you want to type it in the chat, why do you think that is? Why do you think the best bowel habits were on the West Coast and the worst were in the South? Now we're going to compare it to the CDC's obesity chart, and we see that there is a lot of overlap between bowel habits and obesity. And the colors are a little bit backwards here. On the bowel habit chart, the darker the color, the better. On the obesity chart, the darker the color, the worse. But the best was in the West Coast for obesity. That's also the best for bowel habits. And the highest obesity was where we saw, it corresponds to where we saw the worst bowel habits are. So again, why do you think that is? Why do you think that we have a correspondence between the worst bowel habits and obesity in this country? Now we're going to talk about who's the most regular when we talk about different generations, baby boomers, Generation Xers, or millennials. So the baby boomers have a bowel movement at least once a day on average. So when it comes to number of bowel movements, the baby boomers are actually winning. They have normal bowel movements according to the Bristol stool chart. So not just how often they're going, but what those bowel movements are looking like. The baby boomers win again. Constipation at least once a month. The baby boomers have the least constipation and the millennials have the worst. And then as far as diarrhea, again, the millennials are the worst and baby boomers are the best. But it starts to look a little bit different when we talk about food intolerances. The baby boomers have more food intolerances. They have a bowel disease, which would be what we expect, that as you age, then you are going to experience more diseases. And they have visited a gastroenterologist. Again, the baby boomers were the worst in that category, whereas the millennials were the best. And again, why do you think this is? Do you have any guesses as to why the baby boomers would have better bowel habits than the millennials? Yeah, I'm reading the chat, cleaner environmental conditions, stress on the body, diet, yes. I think there's a reason we have an overlap between this obesity and bowel habits and why baby boomers have better bowel habits. So how long should it take to digest food? How often should you be going to the bathroom? There's a wide variety of time. So it takes between 24 to 72 hours for food to completely digest. And it varies according to what you're eating. Protein takes longer than fruits and vegetables to digest. And actually, males' colons are about 8 to 10 centimeters shorter than a female's because a female's wraps around the reproductive organs. So it takes a male less time to digest their food. If we look at the time and where this time is being spent, it takes about a minute, or it should take about a minute in the mouth to chew and digest our food. Again, think about how many of us and how many of our patients are actually spending a minute chewing our food. A lot of the times we don't spend but a few seconds chewing our food, swallowing it, and that's not great for the digestive process. The food spends about 8 seconds going down the esophagus, and the stomach, it spends about 2 to 4 hours, 3 to 5 hours in the small intestine, and about 10 hours to several days in the colon, depending on what kind of foods we are digesting. And it usually takes men about 33 hours on average to digest food, where it takes a woman about 47 hours. One way you can tell how long it's taking you to digest food, I don't know if you've heard about the sesame seed test, but you eat some sesame seeds and then wait and watch to see how long it takes them to come out on the other end, and then you know how long it's taking you to digest your food. So how often should you poop? In an ideal world, eating should stimulate the need to use the bathroom. So on a minimum, at least once a day. And 3 times a day can be considered normal for a person, but sometimes 3 times a day is considered diarrhea. So you need to know if that's normal for the person. And then I would go to the Bristol stool chart and ask what the consistency is. Diarrhea is defined as a change in normal bowel movements with the passage of 3 or more stools per day for at least 200 grams of stool per day, which comes to almost half of a pound. Constipation is defined as straining to have bowel movements, lumpy or hard stools, incomplete evacuation, obstruction, and a decreased frequency of bowel movements. And the Rome 3 criteria require at least 2 of the following over a 3-month duration to be considered constipation. The first one is having less than 3 bowel movements per week. At least 25% of the bowel movements involve manual maneuvers to disimpact, and straining, passing hard stools, or a sensation of obstruction. So I would start, if you're not already, to really get into conversations with your patients. If we just ask them, are you constipated or do you have diarrhea? Then that is very subjective. So we may need to ask more specific leading questions about how often they're going, how they normally go, and then looking at our wonderful Bristol stool chart. If you aren't familiar with this, I do recommend using it with your patients. We have types 1 through 7. Type 1 and 2 are considered more consistent with constipation, whereas our cool guys up here with sunglasses, type 3 and 4, are healthy and normal. And then after that, we start to get a little runny and mushy, and that is considered diarrhea and unhealthy. So we really want a type 3 or 4. And sometimes it's easier for your patients to point to something on this chart rather than try to describe it to you. We also need to be talking to them about color. A little bit of green and any shade of brown is typically considered healthy. If it's super green, then it could mean that you're passing the food too fast or you ate something that was really green. Yellow means that there's too much fat in the stool because of malabsorption, celiac disease. And red could mean that you ate something red first. So I would first see if you ate something like beets. But if it's not because of a food or something with food coloring in it, then it could be dangerous. It could mean that there's bleeding in the lower intestines. If it's pale or white, clay colored, it could mean that the bile duct is blocked. And black, again, I would first ask about food. Did they eat something like licorice, or even an iron supplement could turn the stool black? But if not, then it could mean that there's bleeding in the upper digestive system, in the upper intestinal tract, and that could be dangerous as well. Gray or yellow colored could also be a sign that mucus is making its way to the stool and could be a problem with the liver or gallbladder. Okay, so now we're going to talk about recommendations for these GI symptoms like constipation and diarrhea that are undefined. This happens when we don't know the cause. I think it's very important to first know the root cause before we try to help to remedy the situation. But sometimes we get asked for recommendations for diarrhea or for bloating, and we don't really know what the root cause is. So we're going to talk about some recommendations for that, and then what to do if you know what the root cause is. First, we're going to talk about the causes of these different symptoms to help us better formulate some of these recommendations. And as far as bloating goes, bloating is really common and it occurs in IBS patients. It occurs when we have infections like SIBO, intestinal methane overgrowth, or SIFO, fungal overgrowth. It can occur when we have slow intestinal transit, food intolerances, stress, constipation, overeating, and GERD, as well as metabolic conditions like thyroid disease or diabetes. So if your patient comes in and their complaint is bloating, you may first check to see if any of these apply to them. With constipation, it could be from simple causes like dehydration or having a diet low in fiber. I think sometimes we miss the low-hanging fruit. We need to make sure that we're going back to our patients and asking them if they're getting enough physical exercise, if they are drinking enough water, and if they're getting enough fiber in their diet. And sometimes we can just correct some of those foundational pieces, and we don't need to go into an entire protocol. Food intolerances can also create constipation. And there are certain medications like sedatives, pain medications, and antidepressants, which are really common. So, again, if you're asking your patients about medications and they're also constipated, then you might see if some of the medications, the side effects of those include constipation. Of course, neurological disorders like Parkinson's disease, IBS-C, and other motility issues related to damage to the nerves or muscles in the gut. Some causes of diarrhea include medications, again, especially antibiotics, infections, food intolerances and allergies, inflammatory bowel disease, irritable bowel syndrome, SIBO, metabolic conditions like thyroid conditions, anxiety, and gallbladder removal. We're going to talk about GERD for a little bit. A lot of times we think that this happens because we have too much acid in the stomach, but it can be the opposite, and it commonly is. So hypochlorhydria, or not having enough stomach acid, when this happens, the stomach has to churn more than normal to digest food. So the stomach acid that is there will actually splash up into the esophagus and cause the GERD. So one of the causes of reflux can be not having enough stomach acid. It could also come from too much pressure on the abdomen, such as pregnancy, a hiatal hernia, eating large meals. And again, that goes back to going back to the basics. Can we just talk about diet and how much food we're eating? And could that be causing some of the digestive symptoms? Eating late at night, trigger foods, fatty or fried foods, alcohol or coffee are very common and well known to create some acid reflux, and medications like aspirin and even H. pylori. So when it comes to digestive symptoms, we have two superstars. MegaGuard is great for your constipated patients, and Mega IgG is great for your patients with diarrhea. So I'm going to talk for a minute about those two products. MegaGuard includes licorice polyphenols. This reduces functional dyspepsia, lowers gastric inflammation, mimics pharmaceutical prokinetic agents, and rebalances H. pylori. So it's our upper digestive support. It also contains artichoke leaf extracts that stimulate bile flow and protects the liver from free radical damage and reduces blood lipid levels, and ginger root extract that aids in gastric emptying and improves motility. It also helps with peristalsis and those symptoms like nausea. Mega IgG 2000 is a serum-derived dairy-free bovine immunoglobulin concentrate that binds pathogens and their toxins like LPS. It also helps to reduce inflammation. It improves gut barrier function, and it supplements the immune system with immunoglobulins. It's also used as a prescription by GI doctors sometimes for diarrhea. Mega IgG 2000 binds to a variety of toxins, including Candida and H. pylori toxins, Shiga-like toxins, LPS, C. diff toxins, gliadin, which is a component of gluten, E. coli, staph, Klebsiella, salmonella. So it actually binds to the E. coli, staph, Klebsiella, and salmonella. And recently we learned from research that it will also bind to aflatoxins. And those two products will be in these protocols that I'm going to briefly move through. But again, I would recommend that you grab the slides and go through this in a little bit more detail. So if we don't know what the cause of these symptoms are, this is where I would start. For bloating, I would start with Megaspore Biotic. I always say that when it comes to the probiotics, which are Megaspore, HU58, and Restore Flora, you really can't go wrong, but sometimes there's clinical preference to use one over the other, and that's what I'm going to share with you today is my clinical preference. So Megaspore Biotic contains lichen formis and 4 other bacillus strains, which produce protease and improves protein digestion. So that's my general go-to probiotic when I don't know the underlying etiology and why I would recommend it in the case of bloating. It might help a little bit with digestion. I would also use MegaGuard as a targeted support, and possibly some FODMAPE, which is an enzyme that helps with high FODMAP foods, as well as Wheat Rescue, which has some enzymes, some betaine HCl, and some spores in it. And Zymbiome Dual is one of our newer products. It helps in the case of IBS symptoms to reduce symptom severity by as much as 45%. And that includes abdominal distension and bowel habit satisfaction. As far as all of these symptoms, bloating, constipation, diarrhea, and GERD, I have rebuilding in here. Behind each one of these, there's probably going to be some dysbiosis and leaky gut. So I would also come in with Mega Mucosa and Mega Marine to rebuild that mucosal layer, and Mega Pre to improve diversity and increase short chain fatty acids. I also added some BiomeFX patterns. So these, if you do run our BiomeFX stool test, these are some things you might see on the test that would correspond to symptoms like bloating. We might see hydrogen sulfide production, and that's actually very common for patients that do have bloating to have higher hydrogen sulfide producers. So you will have that for reference as well. If the patient is constipated, then I would probably go with Megaspore HU58 if I don't know any more about the patient. HU58 produces 12 natural antibiotics. It's very gentle. So for your patients that tend to have more Herx type reactions, I will tend to go with HU58. And in the case of constipation, those Herx reactions might increase. So HU58 would be a great choice. I would also go with MegaGuard and some FODMate, and then maybe Zimbium Cope or Dual. Zimbium Cope is very similar to Dual. It has one strain in it and of the Bifidobacterium longum that helps with stress, which a lot of constipated patients have stress, and also with diarrhea. There's a lot of patients that it's connected to stress. For diarrhea, I would start with Restore Flora. It's another superstar in addition to IgG. For diarrhea, it contains Saccharomyces boulardii, which has a lot of research surrounding diarrhea, especially related to antibiotic-associated diarrhea and C. diff. It also contains some of our spores. I would pull in some Mega IgG 2000. That's going to help them get symptom relief very quickly. So the Mega Guard and the Mega IgG will help these patients with symptom relief right away while you continue to work on underlying causes. For GERD, I would start with HU58. It helps to reduce ammonia levels and produces natural antimicrobials that are beneficial with low stomach acid. Ammonia can cause reflux as it is alkaline, and H. pylori survives stomach acid by producing urease, which increases ammonia and elevates the pH of its environment. So HU58 would be very beneficial, as well as Pyloguard. In the extra reinforcement section, you will see Pyloguard listed. This is a product, it's a probiotic that actually binds to H. pylori and removes it. I wanted to talk for just a minute about the HU58 and Restore Flora and when to use one or the other, especially in conjunction with Megaspore Biotic. So there's two different ways I will use them, or two different buckets. The first is to start with HU58 or Restore Flora, and then after a period of time, switch them out for Megaspore. And when I do a biome effects test, or I know more about the patient and their symptoms and what's going on in the microbiome, this is actually where I will start. The second is if the patient is already taking Megaspore and then we encounter a situation such as some type of infection or we just need extra support, then I'll layer in HU58 or Restore Flora on top of it, so add it in. In the case of HU58, it's great for sensitive patients prone to Herx reaction. So if I know that they're prone to a Herx reaction, I will start with HU58. It's also great for extra immune support. So if they are already on Megaspore and they need extra immune support, then I will add in some HU58. Studies show that it reduces interleukin 6 by 45% and TNF alpha by 55%. It also helps to reduce ammonia levels, and it's great in severe dysbiosis with elevated pathogens and SIBO because it does produce natural antimicrobials. Restore Flora, on the other hand, is Saccharomyces boulardii and two of our spores. We have the Restore Flora PD that has 3 of our spores in it, and it's great if a patient is on antibiotic therapy. I always say don't wait until after antibiotics to start going in and trying to clean up whatever the antibiotics did to the microbiome. It's a good idea to have some Restore Flora on hand and take Restore Flora along with the antibiotics to minimize the amount of damage that those antibiotics do. It's also great for your patients who have diarrhea, a candida overgrowth. The Saccharomyces boulardii competes with candida. The cells of the Saccharomyces boulardii secrete capriic acid, which decreases the virulence factors of candida, its hyphae formation, and biofilm development. It also is useful in the cases of H. pylori and E. coli. And for layering it on top of Megaspore, I may do that if basically the same situations as you would use to start with Restore Flora, just as extra reinforcement. So if there is severe dysbiosis and pathogenic overgrowth, especially candida overgrowth or C. diff, diarrhea, or antibiotic therapy, and they're already on Megaspore, then I would add in Restore Flora as well. I actually really like Restore Flora for kids. I find that it's pretty gentle, and I think that because of kids' diets, they tend to eat more sugar and are more prone to yeast overgrowth. So I will usually start kids on Restore Flora. If they're very young, I will start them on HU58, though. Here are the references for those recommendations. And now we are going to get into specific conditions. The first one we're going to talk about is celiac disease. Celiac disease is an autoimmune disease characterized by a lot of GI symptoms: bloating, chronic diarrhea, steatorrhea, constipation, lactose intolerance, and abdominal pain and nausea. It's triggered by gluten. Prolammin peptides, which arise from an incomplete digestion of gluten, activate the innate and adaptive immune response, and leads to villus atrophy, malabsorption, diarrhea, and nutritional deficiencies. As a result, intestinal villi inflammation occur and nutrient absorption is altered, as the villi play a very important role in nutrient absorption. This leads to digestive symptoms like the diarrhea, as well as the steatorrhea and nutritional deficiency and weight loss. The most common nutrient deficiencies we find in celiac disease include calcium, iron, magnesium, vitamin D, E, and the B vitamins. There's a higher prevalence of osteoporosis and fragility fractures in CD patients because of this malnutrition. More than 50% of untreated celiac disease patients have bone loss, so almost half of your celiac disease patients have some sort of bone loss. And we're going to talk a little bit more about why they are continuing to have malabsorption even after being diagnosed and prescribed a gluten-free diet. So there was a study published in 2020 that analyzed gluten-free restaurant foods across the United States during an 18-month period. There were almost 6,000 tests performed by 800 users, and gluten was detected in 32% of gluten-free labeled foods. So these are foods from restaurants, foods they're buying from the supermarket that are marketed as gluten-free foods. Gluten-free pizza and pasta were the worst offenders, and gluten was detected in 53% of gluten-free pizza and 50% of pasta samples. So gluten-free eaters unknowingly consume 5 times more gluten than what would be considered safe for them. 60% of adults with celiac disease never experience complete intestinal healing, even when they're on a gluten-free diet. So it's not enough just to put them on a gluten-free diet and think that they're good to go. We must protect against hidden sources of gluten, and we must address the damage that was created by the disease in the first place. They have a lot of malnutrition and villus atrophy because of the immune process, and we've got to go back in and correct that. Most celiac disease patients don't have a clinical response, meaning that their diarrhea has resolved a few weeks after the gluten-free diet was introduced. However, mucosal recovery does not occur in all patients who have a complete clinical response. So even though they go on the gluten-free diet and a few weeks later their diarrhea might be better, they still have intestinal barrier permeability and mucosal damage. 95% of children diagnosed with celiac disease have intestinal mucosal recovery within 2 years of starting the gluten-free diet. So it takes 2 years for most of them on the diet to have recovery. Recovery rates of adults are less certain, but may take longer than 12 months on a gluten-free diet. Persistent mucosal damage appears to increase the risk of severe complications in patients with celiac disease, even in the absence of symptoms. And 2 years following diagnosis, it was confirmed mucosal recovery was 34%. At 5 years, it was 66%. And this study included 381 celiac disease patients. So only 65% of them had healed 5 years later. Poor compliance to the gluten-free diet, severe celiac disease defined by diarrhea and weight loss, and total atrophy of the villus at diagnosis were strongly associated with this persistent mucosal damage. And that is where our wheat rescue comes in. It removes the gluten and helps to repair the intestinal barrier. It uses targeted probiotics to crowd out unfriendly bacteria to produce short-chain fatty acids to decrease inflammation, to help heal intestinal barrier permeability, and to soothe and repair the mucosal lining. We've got a nice enzyme blend that's acid stable and active at a very low pH. So they cleave the gluten proteins before they reach the duodenum. That's very important. We want those proteins to be cleaved before they reach the small intestine where they elicit the immune response. Tolerase G is an enzyme that prefers to cleave proline. Now, proline is the most difficult amino acid for the body to digest, and it's very rich and high in gluten, but the human body doesn't have any natural way of cleaving this protein. We also included some betaine HCl to aid in digestion of protein and kill off pathogens. Remember that low stomach acid is common in patients with celiac disease, and it can lead to delayed gastric emptying. And we included some lipase because of that malabsorption that is so common with celiac disease patients. In fact, 52% of people with celiac disease have pancreatic insufficiency, and this can lead to deficiency of some of your fat-soluble vitamins like A, D, E, and K and create some of that diarrhea. Celiac disease patients are often deficient in calcium and vitamin D, and these patients would benefit from a vitamin K27, which directs calcium out of the soft tissue and into the bone for stronger bones and less calcification of places like the arteries. Our megaquin D3 contains vitamin K27 and vitamin D. It's a highly bioactive and effective form of vitamin K2 and D3. It supports bone, heart, nerve, mitochondrial, and immune function, directs calcium out of the soft tissue and into the bone. Remember that celiac disease patients have a higher risk of fractures. MK7 has a long half-life, 48 to 72 hours, which is what is in our megaquin D3, compared to popular products that contain MK4, which the half-life is only 4 to 6 hours. It's 100% soy-free, fermented with chickpeas, and is the most bioavailable, bioactive, natural, safe, and long-lasting form of vitamin K on the market. Now, vitamin D deficiency is very common in autoimmune conditions, and the vitamin D receptor is actually downregulated by inflammation, which occurs in celiac disease. So you definitely have more of an inflammatory state with celiac disease, and this is going to downregulate that vitamin D receptor. And when that happens, the body can't utilize vitamin D as well. Some of the other things that will interfere with the vitamin D receptor are infections, and dysbiosis is very common in celiac disease. And also aging, stress, and toxins can all impact the vitamin D receptor. Part of the purpose of the vitamin D receptor is to help regulate who is in the microbiome. So it helps to prevent dysbiosis. The vitamin D receptor can actually alert Paneth cells in the gut when there are pathogens, and then the Paneth cells secrete antimicrobial peptides. Pathogens can target the vitamin D receptor by producing LPS, lipopolysaccharide, and proteins that bind and inactivate the vitamin D receptor. So it's one of their mechanisms is to target this vitamin D receptor so it can't alert the Paneth cells that they're there. Monitoring vitamin D status in these patients, as well as addressing inflammation, pathogens, stress levels, and toxic exposure is important. And otherwise, the vitamin D receptor won't be able to utilize vitamin D properly. So I have a little celiac protocol here for you. And the first part of this protocol, what I would do if I had a new celiac disease patient is first and foremost, do a biomass stool analysis on them and get an idea of what their microbiome looks like. And that helps us to better create focused protocols. I call phase one the protect, calm inflammation, improve digestion, heal, and repair. So during the first month, we're going to start with wheat rescue. That's going to help with any kind of hidden gluten that could be in the food. And as we saw, that's really common. Even if they think they're eating gluten-free food or food that's labeled gluten-free, then there's a great chance that they are still being exposed to gluten. So anytime that they eat out at a friend's house or they eat one of those prepackaged foods, they should take some wheat rescue with it. In addition, Mega IgG 2000, Mega Marine helps to rebuild that mucosal layer, and Mega Quin D3. Also, Mega Guard if they're constipated or bloating. And then during month 2, I would add in Mega Mucosa. So this is going to take you through the total gut restoration. You may notice that I don't have Megaspore on here, and that's okay. The Wheat Rescue has some spores in it. You could certainly add some Megaspore in addition to this. During phase 2, we're going to protect and continue to rebuild, and phase 2 can go on as long as you need it to, meaning that it really depends on your patient. It depends on their symptoms, what kind of improvement they're getting, and it depends on what state they came in with, how long it will take them to repair their microbiome. But during month 3, you would add in Mega Pre, the third step of the total gut restoration. You would continue Mega IgG 2000 if diarrhea were a problem or if they needed extra inflammatory support. And then for the maintenance dose, once you feel like their intestinal mucosal barriers have healed, they're in a much better spot, then you can move on to maintenance. And that would be Megaspore about 2 times a week, Mega Pre once a week, and Mega Mucosa once a week. I would also continue to add in Mega Marine and Mega Quin D3 based on testing. I do believe it's important to do some vitamin T testing and follow your patients and see how they're responding to the dose that you are giving them. They may need some additional nutrient support along the way as well. They probably will if they have some malnutrition and curcumin to help with inflammation too. And then Wheat Rescue is needed. They can get to a spot where they just use Wheat Rescue as an insurance policy if there's any chance of a food being possibly contaminated. I wanted to share a quick case study with you. This was a celiac disease patient that I worked with. They were diagnosed with celiac disease about a year before we started working together. They had a slow healing fracture, no idea why. The doctors didn't know why, but we know that that's very common in celiac disease because of malnutrition. She also had a lot of digestive symptoms still, constipation and bloating. She had bone pain, fatigue, recurrent bronchitis, draining of the ears, UTIs, and mold exposure. And like I mentioned, she was very strict with her gluten-free diet and very compliant with whatever she was asked to do. About 1.5 years later, we'd been working on nutrition and diet, avoiding a lot of foods that she was sensitive to, low histamine foods, low mold foods. We added some fish oil and some digestive support, worked on oxidative stress and histamine. She was making slow but steady progress, including more energy and less bone pain, less constipation and bloating. And then we added in Megaspore, Mega Mucosa, Mega IgG 2000, Wheat Rescue, and K27. About a month later, she had fewer episodes of bronchitis and she was able to recover without antibiotics. She had less bone pain, and then she started Mega Pre. About the same time, she figured out that she had a mold issue in her house and they started remediation. And about a month later, after being on the total protocol, she reported that she didn't know what was helping, but she had always had an issue with her ears draining and swelling and causing a lot of infection, and her lymph nodes were swollen as well. But since she was on the protocol, she hadn't noticed anything, and she was really surprised that she didn't have to be on any antibiotics, and the ears draining had just stopped, and the doctors didn't know why. And we know it was because probably the remediation and addressing the mold, but also healing her gut made a big impact to the inflammation all over her body. Okay, so now we're going to switch gears into community-acquired C. diff. If we talk about C. diff, historically, it has been regarded as an infection among the elderly originating from hospital settings. But there's been more recent evidence to suggest that community-acquired C. diff is occurring in younger patients without comorbidities. There was a study examining community-acquired C. diff from 1991 to 2005, and it reported that people with community-acquired C. diff were younger, female, and had fewer comorbidities and less likely to have severe infections or exposure to antibiotics compared to patients with hospital-associated C. diff. And I actually see this in practice quite often, that it's younger females who don't have diarrheal type infections, but they might have rashes, which we're going to talk about in the next slide, or maybe just a little bit of GI upset. And a lot of times it's asymptomatic. C. diff spores are non-infectious until they're ingested and germination occurs. Ingested spores remain dormant in the colon until normal bowel flora are disrupted, at which time they germinate. So a lot of us are just carrying around C. diff, not causing any issues. They're opportunistic. So whenever they do have the opportunity, then they will create an infection. There was a pediatric study of C. diff and arthritis, and they found a rash in 54% of patients beginning about 10.5 days after initial GI symptoms began. 93% of patients diagnosed with C. diff associated disease had contamination of at least one skin site. So it's easy for contamination to occur between the gut microbiome and the skin. 1 to 4 weeks after treatment, 56% of patients with C. diff infections were asymptomatic carriers of C. diff, and after diarrhea had resolved, skin contamination was 60%. For C. diff recommendations, we briefly mentioned Restore Flora and Mega IgG 2000. Saccharomyces boulardii in the Restore Flora is a commensal yeast studied for its benefits in fungal infections, H. pylori, and C. diff. The release of antimicrobial substances from Bacillus clausii, which is also in Restore Flora, are active against Staphylococcus, Enterococcus, C. diff, and it increases SIBO decontamination rates. Bacillus subtilis also forms 12 natural antibiotics and helps to optimize the pH and encourage the growth of commensal keystone species and short-chain fatty acid producers. One of the paradigms that we subscribe to at Microbiome Labs is a lot of times it's about crowding out these pathogens or opportunistic microbes with beneficial species. So a strategy that we can use is to build up the beneficial species, and then they'll help police the bad guys so that they don't overgrow. Mega IgG 2000 binds to C. diff toxins and virulence factors. It reduces inflammation and improves gut barrier function. And then I would also include some Mega Mucosa and Mega Marine to rebuild the mucosal layer. Next, we're going to talk about small intestinal fungal overgrowth. Candidiasis is known to cause GI symptoms in immunocompromised patients or those receiving steroids or antibiotics, but we know that it occurs very often in everyday life, even in patients who are not immunocompromised. There's emerging evidence that SIFO, or small intestinal fungal overgrowth, is related to unexplained GI symptoms in non-immunocompromised subjects. Two studies showed that 26% of studied patients with unexplained GI symptoms had SIFO. So also fungal overgrowth is very hard to detect on tests. There's all different kinds of tests, and they have pros and cons for detecting fungal overgrowth. But what I always say that if you don't know for sure and you have the symptoms, then you can treat, as long as you pick a treatment that's not going to harm the overall microbiome. But I do find that sometimes patients who it doesn't appear that they have any other kind of GI symptom condition, and we can't figure out where their symptoms are coming from, a lot of times it is a hidden fungal overgrowth. And remember that can happen in about 26% of patients. So about a quarter of them could have this hidden fungal overgrowth. Most common symptoms are belching, bloating, indigestion, nausea, diarrhea, and gas, which are very vague symptoms that could occur with just about any GI condition. The underlying mechanism may be small intestinal dysmotility or the use of PPIs. So if you had to guess, how often do you think that PPIs are overprescribed or overused? PPIs are probably one of the most prescribed medications and are overprescribed for poorly defined reasons or conditions where PPIs have not been shown to be beneficial. And evidence suggests that PPIs are often overused in 25 to 70% of prescriptions, having no appropriate indication. In the US, PPIs account for more than $10 billion in healthcare costs, and the global cost exceeds $25 billion per year. So those are just a few statistics for you on PPIs. Of course, they have their place, but they're way overly prescribed. The appropriate use for PPIs include anything that's short-term. It's supposed to be short-term use, and I feel like that rarely happens. Doctors will put patients on PPIs and never take them off. But an appropriate use would be for H. pylori, erosive esophagitis, gastric ulcers, or stress ulcer prevention in high-risk critically ill patients. One of the main inappropriate uses of PPIs for long-term treatment is functional dyspepsia or indigestion. And the long-term use may be associated with C. diff and pneumonia. So these are some of the risk factors of being on a PPI for a long period. C. diff and pneumonia, dementia, decreased bone mineral density, possible interaction with antiplatelet agents, development of various micronutrient deficiencies, role in the development or progress of chronic kidney disease, and fungal overgrowth. So a lot of times if your patients have been on a PPI, or even if they have hypochlorhydria and don't have enough stomach acid for some reason, it can lead to a fungal overgrowth. So I'm going to walk you through our Candida protocol, and it starts with mega-macrobalance, which contains undecyclinic acid that inhibits formation of the hyphae of the Candida. These are like the roots. And B-propolis inhibits yeast proliferation, and mega-IgG 2000, which helps to reduce gut permeability and bind toxins, restore flora. Remember that the Saccharomyces boulardii decreases Candida albicans virulence. And also remember that Candida management should rely heavily on building the competitive commensals. So we can go in as much as we want and try to kill off this yeast or Candida, but it's probably going to come back unless we're occupying that space in the microbiome with commensals. So part of the strategy should be to rebuild the commensal bacteria, and I recommend following this Candida protocol with the total gut restoration. Okay, so this is an example of a patient's BiomeFX test, and this patient had been on PPIs for a very long time. But first, I'm going to show you what our pattern for PPI use would look like on BiomeFX. So if you're doing our BiomeFX functional microbiome analysis, I always talk about patterns. And this means if you go to the research and look for any condition like fungal overgrowth and the gut microbiome, then the research is going to pull up different papers that have groups of bacteria or microbes that tend to be elevated in those conditions and groups that tend to be lower. It'll also have metabolites of those microbes as well. So that's what we're looking at, are these patterns. If someone didn't have enough stomach acid, or they were on PPIs, what would the bacteria and the microbes in their microbiome look like? And for PPIs, it would be that they would have reduced alpha diversity, increased pathogens. Stomach acid is very important for killing off pathogens. So we would expect that they've been on PPIs for long term, they would have more pathogens like C. diff and E. coli and H. pylori. They would have increased families of enterobacteria and staphylococcus, elevated bifidobacteria, or actinobacteria. This may sound counterintuitive because we know that bifidobacteria, which is in the actinobacteria phylum, is found in probiotics. So we think it would be the opposite. However, when we don't have good stomach acid, we're not digesting food appropriately, and it'll end up in the colon to be digested, and that will throw the balance of the pH and the microbiome off. And actinobacteria will often overgrow in those conditions. And a lot of times we see that it's more the pathogenic actinobacteria that are elevated in those conditions. Also, fungal overgrowth, which we see as Ascomycota, oral bacteria being overrepresented, and that's again because we don't have the stomach acid to kill off those oral pathogens. And then I would always combine that with patient symptoms. So does the patient have signs of being on a PPI or not having enough stomach acid? So here's the patient. The patient was a 20-year-old female college student, and this patient had been on a PPI basically since they were born. They had reflux when she was an infant. They put her on a PPI and never bothered to take her off. So she said that she didn't really have any GI symptoms. However, she didn't really like to eat food, and she got very full quickly after she began to eat. So that's a sign of not having enough stomach acid. Her main complaint was stress and anxiety. And on her biome we saw a lot of pathogens, very low diversity. But what really gave it away here was that she had actinobacteria was very high, proteobacteria was very high. So a lot of pathogens are in proteobacteria. But also we just talked about the actinobacteria and how it can be elevated when we don't have enough stomach acid. Synergistices we see in the bottom, that's an oral pathogen or oral phylum, and then Ascomycota was at the 95th percentile. We should see this at 0. That is the phylum for yeast and mold. So this low stomach acid had led to, or not having enough stomach acid had led to a pathogenic overgrowth as well as a fungal overgrowth. And I like to remind people that in infants, it's very common to have reflux because the esophageal sphincter isn't fully developed. And when we overfeed, then the small stomach reflux can happen, but infants usually outgrow it about 1 year old, and it usually doesn't require treatment. So it's a shame that no one came back in and took her off of the PPI, and she'd been on it for 20 years. It really disrupted her microbiome. And next, we're going to talk about IBD. Inflammatory bowel disease symptoms include stomach cramps, diarrhea, constipation, rectal bleeding, and loss of appetite. In Crohn's disease, we see ulcers, infections, and narrowing of the intestine. On biome effects, a pattern that we might see would include low alpha diversity, fusobacteria, which is really inflammatory, proteobacteria, low prosnuclei, which is a keystone, and then some low short-chain fatty acids, as well as elevated pathogens like Klebsiella and E. coli. We have new research that shows it took fecal samples from patients with IBD, and they were studied before, during, and after 5 days on the total gut restoration. And we know that IBD patients with active UC have lower levels of short-chain fatty acids than those in remission. So 5 days of total gut restoration significantly increased short-chain fatty acid production. It increased the abundance of some of the beneficial species like Bifidobacterium and Lactobacillus and Rhamnococcus. TGR provided protection against inflammation-induced barrier disruption, and there was less immune cell-induced damage on the gut epithelium. There were also anti-inflammatory cytokine release was greater and pro-inflammatory cytokine release was lower. Our IBD protocol includes megamarine. This stimulates the release of intestinal alkaline phosphatase that modulates the microbiome by reducing LPS production and gut permeability. And EPA has actually been shown to improve goblet cell differentiation and reduce mucosal inflammation. So it stimulates the goblet cells to make more mucus, which leads to a healthy mucosal barrier. One study showed that 6 months of EPA reduced fecal levels of calprotectin in patients with UC. Also, in addition to the megamarine, add in some mega IgG 2000, especially in the case of diarrhea. A 12-week study on IBD patients showed that those taking the mega IgG 2000 were nearly 3 times more likely to report clinical improvement of symptoms and no negative side effects. Okay, we have a lot of presentations that we've done on SIBO, so I'm not going to go in too much detail about SIBO because you could talk for quite a long time about SIBO, but I'm going to briefly mention our SIBO protocol here. So some symptoms of SIBO include bloating, diarrhea, constipation. It overlaps with small intestinal fungal overgrowth, H. pylori, IBS, IBD, and type 2 diabetes. hydrogen methane, which is intestinal methane overgrowth, or hydrogen sulfide dominant SIBO, all share similar foundational approaches for correcting the bacterial infection. So when it comes to our SIBO protocol, you're going to start at the same place, no matter which one of these it is, with the exception of maybe adjusting for specific symptoms like diarrhea or constipation. A little clinical pearl for you: if you do use our BioMFX functional microbiome analysis, we cannot diagnose SIBO, but we do see patterns for methane dominant and hydrogen sulfide dominant SIBO, especially when it correlates to patient symptoms. What we would see on BioMFX for methane production would be higher eukaryota, which are the archaea that actually produce methane at the family level, methanobacter at the family level, or eukaryote at the phylum, methanobacter at the family, and then we would see elevated methane producers in the function section. For hydrogen sulfide dominant SIBO, we might see desulfibrio in the family level on the fingerprint section, Bilophila wadsworthia at the pathogen section, and hydrogen sulfide at the function section. And I always recommend, again, seeing how this aligns with the patient's symptoms. Do they have the symptoms of SIBO? Because when we're doing a stool test, we're looking at the large intestine, not the small intestine. But many times when these bacteria overgrow in the large intestine, then they can move up to the small intestine and create some issues there. So our SIBO protocol would be HU58. This produces natural antimicrobials and some that target pathogens like albicans or fungal overgrowth, as well as mega IgG, especially if they have diarrhea, mega GARD for constipation, and our FODMate. FODMate is an enzyme blend that supports the digestion of fermentable oligosaccharides, disaccharides, and monosaccharides. So it's very helpful for patients that you would put on a low FODMAP diet. Okay, so our key takeaways: digestive issues point to a bigger problem. It's important to have a deep conversation with patients about their symptoms. Make sure you're defining constipation and diarrhea with them. Use the Bristol stool chart as well. That can be very helpful. The absence of diarrhea in celiac patients does not equate to recovery. Wheat rescue can prevent damage from accidental exposure and facilitate recovery. Vitamin K27 can facilitate bone health and related to malabsorption. Community-acquired C. diff is very common and often seen in young females with no comorbidities or antibiotic use, and it may be associated with a rash. As many as 26% of patients with unexplained GI symptoms have small intestinal fungal overgrowth, especially if they have a history of steroids, antibiotics, dysmotility, or PPI use. And our new study showed 5 days of the total gut restoration improved the abundance of helpful species, short chain fatty acids, less immune cell induced damage to the GI epithelium, elevated anti-inflammatory release, and lower pro-inflammatory and cytokine release. And here's our coupon code for today. I'll leave that up for a moment and see what kind of questions you have.
Thank you so much, Star.
You're welcome.
Lot of comments and questions in the chat, and there's lots in the Q&A box, so you go ahead and just tackle it for whatever end you'd like to. We'll take as many answers as you can give us.
Yeah, so I see one. This is a good question. How young is very young for HU58 and Restore Flora? So we haven't studied these supplements in the pediatric population or in pregnancy, but I do know that some providers will use HU58 in infants. And if you're doing that, I would open the capsule, put just a little bit of the powder on your finger and give it to them that way. It doesn't take much. So it can be used in infants. I usually start HU58 with infants to toddlers, and then after that age, we'll do Restore Flora. And you said that Megaspore Biotic has proteases. Clarify that because I don't see it in the ingredients. Yeah, so the spores actually create the protease themselves. So the bacterial spores that are in Megaspore will create the proteases. It's not an additional ingredient in the product. go over to the Q&A box. Oh, y'all got lots of good questions. Is there a webinar on BioMFX and how to interpret results? We have lots of webinars, so I would ask your sales rep or customer service to reach out and get those links for you. And also, if you do a BioMFX stool test, one of the best ways of really learning is just to do a test on yourself and then go through an hour consult with one of our consultants. And that's really where you'll get the best learning on BioMFX, but we definitely have webinars we can share with you. Can you complete the Candida protocol in breastfeeding women? That's a great question. So there's not necessarily any of the ingredients in the products that are harmful on the Candida protocol for breastfeeding women. But when it comes to pregnancy and breastfeeding, I don't like to do anything that's going to release a lot of toxins because that's going to go to the fetus or it'll go to the infant in the case of breastfeeding. I would do, I think, Restore Flora and IgG. I may hold off on the Mego Micro Balance until the breastfeeding has stopped. Oh, really stinky gas that lingers a long time. I think the question may be where that's coming from, but actually we see that a lot with BioMFX. It usually comes from hydrogen sulfide producers, especially if it smells like rotten eggs. And in that case, you could see if you take out foods that are higher in sulfur, like eggs and cheeses, do those symptoms get better? And if you eat foods that are higher in sulfur, do they get worse? A lot of times that's where it's coming from. Also, just digestive issues, which could arise from not having enough stomach acid, not having enough enzymes, not having good bile flow. That can lead to some of those symptoms too. Duration of therapy for Restore Flora and HU58. It's not really black and white, and I know that that can be difficult sometimes, but it really depends on the patient and their symptoms and how fast they're improving. If they're doing Megaspore and then they add in HU58, for example, because they have some type of infection, then usually going through a bottle of HU58 is enough. But it really depends on what's going on. It's not harmful to stay on them long term, but if they're not getting better, then we need to do a little bit more digging and try to figure out what the root cause is and how we can add some additional support for that root cause. Do you HU58 reducing ammonia levels on stool tests? Yes. So HU58 can actually utilize some of the ammonia, so the Bacillus subtilis. So in that way, it can decrease ammonia, which we would see in a stool test. It also reduces some of the ammonia producing bacteria. What tips or products do you recommend to help patients increase transit time? MegaGuard would be a go-to, but also you just want to start at the top and think about digestion all the way down and try to figure out what is causing the issues with transit time. Sometimes conditions like celiac disease can create some dysmotility. Sometimes it's that we're not digesting things. Maybe we don't have enough stomach acid or we don't have enough bile flow, which is where MegaGuard comes in. There's various things that could lead to decreased transit time. So we want to try to figure out what the root cause is. But in the meantime, MegaGuard is very beneficial. Adding in some magnesium citrate, something like that can be beneficial too. Okay, I'm going to take one more question. Any recommendations for chronic fecal urgency, unpredictable, but otherwise normal consistency bowel movements? So probably the first thing I would do is talk to a GI doctor and make sure you rule out any kind of IBD. The Mega IgG 2000 could be beneficial in that case too. It is prescribed to help with diarrhea in cases like HIV and IBD, so that could be helpful too. But again, it goes back to figuring out what the root cause of that is and why we have an issue with the fecal urgency. Okay, Angelica, I think that's it. If y'all have any questions that didn't get answered, if you could let your sales rep know, they'd be happy to help you or reach out to me if they need to.